I want to thank you all for spending your Saturday morning with us. Thank you for this great turnout, and Dr. Sway and Dr. Kitri for organizing. I'm going to talk to you today about pediatric uveitis. These are my disclosures, and relevant to this talk, I will mention the use of off-label but FDA-approved medications, as there are no specific drugs that are FDA approved for the treatment of pediatric uveitis. So just some facts for you. The incidence and prevalence of pediatric uveitis is lower than adult uveitis, which in general is a rare disease to begin with. But although it is less common in children, the devastating visual impairment that results is lifelong for these kids. So, of course, these children that are in the amblyopic age range, they develop complications of uveitis. This can affect their entire life. It'll affect their ability to go to school, get a job, etc. Anterior uveitis, amongst all forms of uveitis, is the most common in the pediatric population. There's a slight female predominance. In the United States, at least, within children with pediatric uveitis, autoimmune etiology is the most common. That may not necessarily be true in other countries. Bilateral involvement is the most common, and most of these children have chronic and/or recurrent disease. So there are many causes, and we could spend the entire talk just talking about these, but I think in the interest of time, I just wanted to give you some general concepts on how to manage these patients. Within autoimmune etiology, the most common association is by far juvenile idiopathic arthritis, or used to be called JRA, but we call this juvenile idiopathic arthritis now. There are also infectious and other masquerade conditions that can cause pediatric uveitis. In a series in India, the most common cause of pediatric uveitis was infectious, and these were some of the etiologies, but less common in this country. So in our cohort of patients referred to UCLA, the complications of chronic uveitis are listed here, and you can see that if a child in the amblyopic age range had any of these complications, these would cause visual compromise and potentially amblyopia. And these complications tend to occur early in the course of the disease and are associated with vision loss. So because we're talking about kids, amblyopia is a unique consideration that we don't need to worry about in adults. As I said, JIA-associated uveitis is very common, and a lot of these kids present to the ophthalmologist already legally blind by the time we see them initially. So unfortunately, they're not being screened properly, or they're not being referred promptly. Children with uveitis have a very aggressive immune response. So even though you may say, well, what's such a big deal about them having a cataract? Cataract surgery is the bread and butter for ophthalmologists. Well, these kids can get an exuberant inflammatory response after cataract surgery, and you can end up with a picture like this. So I think if a child with uveitis never ends up having to go to the OR for cataract surgery, that is a win for us. So there are a lot of special considerations in this population compared to adults. I want to point out some of them for you today. So the prognosis is worse because of the possibility of amblyopia and irreversible blindness. Even low-grade, smoldering inflammation can lead to the complications that we were talking about. And most of these patients have chronic or recurrent disease, and so they require long-term treatment. And that means they need long-term follow-up. And so compliance is a big problem, both compliance with medication and compliance with follow-up. It's very taxing on both the child and the family. So you want to be able to sustain a very good rapport with the family, with the child, and plan for that to be a long-term relationship. And most of these kids, especially with chronic disease that is not able to be controlled with steroids only, require systemic treatment, and most of those will need a team approach. So we'll talk about that too. So these are 4 eyes from 2 patients of mine who had JIA-associated uveitis and were poorly controlled. And as young adults in their early 20s, they came to me for their first visit saying, I'm blind, fix me. I can't fix this. These patients at this point weren't inflamed. And you can see that they had cataract surgery. And maybe the patient looked great coming out of the OR, but now in their early 20s, when they should be going to college, starting their lives, they're legally blind. So I want to give you some pearls on how to avoid this. So pearl number 1 is be aware that children with active inflammation may be totally asymptomatic. You might have a child with a white eye who doesn't complain of anything, is not complaining of photophobia, doesn't tell you that there is anything wrong with the vision. So this is in direct contrast with adults who will definitely tell you there is something wrong. So you don't rely on the fact that the patient doesn't have a red eye, doesn't have ciliary flush, is not saying they have any pain. And they might be completely unaware that they have decreased vision, or they have no way to tell you that that is happening. And so one common way that this presents is that the parent notices something on the eye. Maybe they notice a leukocoria, or they come in saying, the color of that eye changed, or the one eye is wandering, and they come in for screening like this. So you want to be able to perform a very careful examination of these patients and look for the presence of anterior chamber cells. So that means a real slit lamp exam with the lights off. These kids, all of us that treat children know it's a challenge to look at the eyes of children. But for this purpose, a pen light exam is not sufficient. Don't trust the fact that, the kid is not complaining of pain, the eye is not red. Most likely, there's no cells. I'll just take a quick look, and if I don't see anything obvious, no, you cannot rely on that. So for the non-ophthalmologists in the room, I just want to explain to you the way we look for anterior chamber cells. We're looking for white blood cells floating in the aqueous, and we categorize this on a 0 to 4 point scale, with 0 being no inflammation. Hopefully that's what all of us in this room have, where 4 plus is they have a hypopion. So we count the number of cells per high power field, and we convert that to a scale. So what I want to say here is, for the ophthalmologists in the room, grade the anterior chamber cells, but please kind of translate that into English when you're speaking to the non-ophthalmologist, the rheumatologist or the pediatrician who is co-managing the patient with you. So, instead of telling them this is how many cells the patient has, please say, the eye is quiet or the eye is actively inflamed. I think that makes the communication a lot more straightforward, but just letting you know how we come to that. Any degree of ocular inflammation requires treatment. Don't think that because they only have 1 plus cell and the kid is not in pain and the eye is not red and nobody's complaining about anything, that that's okay. When we talk about acute inflammation, the mainstay of therapy is still the same as for adults, so that is topical corticosteroids, topical cycloplegias. Those are the mainstay of treatment. For very severe cases, we will add systemic corticosteroid, but for the most part, I would say, start with this, but after they're quiet, you of course have to taper down on the topical steroids, and don't say, okay, you're great, bye, come back PRN. So even after the patient is off topical steroids and quiet, please still follow them after you've tapered the drops, because as I said previously, a lot of these patients have chronic or recurrent disease. So if we're going to talk about a patient that has gone from acute to now they have chronic disease, chronic use of topical corticosteroids greater than 4 times a day is not recommended. There was a study done out of the Wilmer Eye Institute looking at pediatric uveitis cases, and their conclusion was that any patient using 4 times a day or more of topical steroids on a chronic basis developed visually significant cataracts. So that's not to say that 3 times a day or less is necessarily always safe and that never causes a cataract. But as a rule, I use this, if the patient can't get down to less than 4 times a day, I feel like that by itself, to me at least, signals to me that I need to move on to systemic treatment. And so a mistake would be to think, well, why don't I just reduce to a weaker corticosteroid? And if I reduce to a weaker one, well, maybe that's better for cataract formation or glaucoma. And maybe it's okay for the patient to have trace to 1 plus cell, especially if the patient is not complaining. That is also a mistake, because you will regret that. The patient will develop complications eventually. Pearl number 5 is that band keratopathy in a child is a case of uveitis until proven otherwise. So what we're talking about is a collection of calcium deposition on the cornea. A lot of times this is noted first by the parents. They'll say that the eye looks dull or that the color of the eye has changed, but what they're really talking about is this haze in the cornea. So as an ophthalmologist, you might be referred this, with a number of complaints, which might not be that they think the patient has uveitis. So please look carefully for other sequelae of chronic inflammation. Please look carefully for anterior chamber cells. This often can be the very first presenting symptom of JIA. So that brings me to my next point. Understand the screening guidelines for children with JIA in terms of when and how often they need to be screened for uveitis. So the most common subgroup within these children who are at highest risk for pediatric uveitis is the ANA positive oligoarticular subgroup. So all kids who are diagnosed with JIA should have an initial screening with an ophthalmologist within 1 month of diagnosis, regardless of which subgroup they fall into, regardless of their vision or any ocular complaints. And then the follow-up after that is based on risk category. So on the left here, you see, I don't know how to use this. So the ANA positive oligoarticular, so very few joints involved, with the onset of arthritis being less than 7 years old and the duration of arthritis being less than 4 years, those kids are at highest risk. And so they should be examined every 3 months for 7 years. Now, if you are doing that and they don't have uveitis, that is the screening recommendation. But if they have uveitis, then you need to see them more often. So for me, after I have gotten the patient under good control, so in the acute phase, I might see them every 2 weeks just to make sure that they have gotten quiet. But I'm talking about once they are well controlled on medication or not, I see those kids every 6 weeks. On the other hand, patients who are at low risk, so with systemic onset of arthritis, they usually have very bad joint disease, multiple joints involved. If they have no eye disease, they can be examined every year. So be aware of the complications associated with the use of corticosteroids in children. So as ophthalmologists, we're very aware that topical steroids can cause a cataract, can cause glaucoma, and certainly these children are at risk for those with the added risk of developing amblyopia. And there are also systemic risks with use of systemic oral corticosteroids. But specifically for children, I want to point out that growth retardation is a risk if you're using chronic oral corticosteroids at a dose of prednisone 3 milligrams per day or equivalent. And so these kids can catch up if they get growth hormone, but it would be better to just avoid this completely. So I have a case to illustrate this point. This is a 14-year-old girl. She has a history of JIA. She basically has no joint disease or very well-controlled joint disease on methotrexate. But she has uveitis bilaterally, and she's a steroid responder. This is a very common scenario. She also has CME. So you see that her intraocular pressures are high. She's on max topical glaucoma drops, and she had to add oral neptazine to control this intraocular pressure. So this is, for us, that means the patient is on maximum medical therapy for glaucoma, because she can't get off the topical prednisolone. So, but the thing is, she is on methotrexate. She is seeing a rheumatologist. So the patient was brought, her father brought her to see an local ophthalmologist who mostly takes care of adult retina, and said to the dad, why would you treat your daughter with systemic therapy for an eye disease? Let me give your daughter intravitreal Kenalog, because it's an eye problem. Why don't we just treat the eye with medication into the eye? Keep in mind, this is a 14-year-old girl with no cataract. So the dad was kind of antsy about this, so came for a second opinion. And by the way, this is how the retina looks. So she's got macular edema, or cystoid macular edema is a complication of chronic inflammation in the eye. Added topical NSAIDs and didn't really help. So I suggested that the patient be switched from methotrexate to a biologic, a TNF alpha inhibitor, and luckily for me, the parents agreed with me. So now the patient, after 3 infusions of infliximab, vision is 20/20. Patient is off all drops. She's not on any glaucoma drops, not on any prednisolone. IOP is 16 and 15. To me, this is a winning situation. So I think, if she had gone the other way and had intravitreal Kenalog, she would have had to have repeated injections. By the time she graduated from high school, she would have had a cataract and would have needed cataract surgery. So I think I'm very happy with the outcome of that situation. So my next pearl is that we should aim for durable remission with, therefore, the preservation of vision. And that should be our goal. It shouldn't be short-term control, but we should be wanting to take care of this child so that they grow up into an adult with good vision. So if I make an analogy, our rheumatology colleagues would look at this hand and say, we want to keep this hand looking like this. We know that chronic inflammation in the joints will lead to permanent joint deformity. So the analogous situation for us is we start with a kid with a normal eye. We don't want that eye to end up like this. So a lot of these kids do need systemic therapy. So my next pearl is to consider referral to a uveitis specialist and or a rheumatologist earlier in the course rather than later in the course. A study by Stephen Foster showed that the average or the range of time between diagnosis of uveitis in the child and referral to the uveitis specialist was 6 months to 13 years. And as I said previously, many of these patients, like 22% of GIA kids alone, upon presentation are already legally blind. So when steroids are not cutting it, we have to move on for the sake of the child, for their vision and their systemic health. And so to take a lesson from the rheumatologists, I think that these kids need to move on to what we call DMARDs, or disease-modifying anti-rheumatic drugs. We name them this because they have the ability to prevent radiologic joint damage. So in that sense, it's just like those 2 eyes that I showed you before. We don't want the kid to end up with permanent complications. And rheumatologists employ these medications pretty early in the disease course. However, the analogous situation doesn't exist for us. We don't have specific guidelines to say when DMARDs should be employed in pediatric uveitis. And I think because of that, and also probably because of inappropriate screening or maybe the inavailability of uveitis specialists that take care of these kinds of children, we risk that steroid monotherapy gets inappropriately prolonged for these kids, and then they get complications from the steroids in addition to complications of the uveitis. So, oh, something happened. So we recommend that for kids that fall into this category that are going to need systemic therapy, a good way to manage these kids is a team approach. So if that means the pediatric ophthalmologist with the pediatrician, or the pediatric rheumatologist with the general ophthalmologist, whatever it is, one person to manage the medications and the systemic disease, one person to monitor and manage the eye disease. However you want to do it, that's fine. But all the team members should be in concordance of whose responsibility it is to do what. I think a big problem can be that the rheumatologist thinks, well, this is an eye disease and I'm not an eye doctor, so it's that person's responsibility. And the ophthalmologist thinks, well, I don't know what these drugs are doing. I don't know how to monitor these medications. That's that person's job. If the eye becomes inflamed, even on these medications, that's not my fault. So that's a bad attitude to have. Everybody is working as a team to help this child. If the patient ends up doing well, that's a win-win for everybody. And of course, don't forget the routine general ophthalmologic care for these kids, like refraction and wearing polycarbonates, especially for monocular children. So don't lose the forest for the trees. So in summary, children with ocular inflammation often present with few or no symptoms and already have vision loss at the time of presentation. Severe vision loss with uveitis is preventable, but usually requires long-term follow-up and a multidisciplinary approach. Topical steroids are the mainstay of therapy for acute episodes of uveitis, so that's either the first acute episode or breakthrough flares while on chronic therapy, but should not be used more than 4 times a day on a chronic basis. Consider risk of amblyopia as a result of complications from either inadequately controlled inflammation and/or the use of chronic corticosteroids. And consider referral of these complex cases to uveitis and/or rheumatology, especially if systemic therapy is necessary. So thank you very much for your attention. This is my contact information if you need. Yes, sir.
Do they ever use Durezol in ophthalmic drops?
Sure, but be aware that the steroid response associated with Durezol is even worse than with prednisolone, and kids, as Dr. Giacconi mentioned before, are exquisitely sensitive steroid responders. So you can get a super high pressure very easily.
Yeah. I've been on them for about 4 years.
But you're an adult.
Crohn's disease and ankylosing spondylitis, and they work much more successfully for me than prednisolone.
Yes, that is because
But I'm an
Durezol is
adult.
more, so Durezol is much more potent steroid than prednisolone. So 1 drop of Durezol equals 2 drops of prednisolone, but, I am very wary of the side effects of these medications. So for short-term use, yes, I think it is appropriate in certain situations. I don't want to say, yeah, use Durezol for all the pediatric uveitis cases. Anyone else? Oh, you have a comment, Michael.
Yeah, I was going to comment on
Yes.
what the gentleman just said.
So Dr. Kapamagian is also a pediatric uveitis specialist and a glaucoma specialist. So I'd like to hear what you have to say about Durezol.
Thanks for that. It's actually well published, and actually in one of the symposia that Olivia put together had presented on this. The latency and the incidence of steroid response in children with Durezol is a lot higher than in adults. So I wouldn't compare success in an adult and translate that over to applicability in a child. I would be very hesitant to put a child on Durezol myself as well. And that one case you put up there, if she had gotten the steroid response, I'm pretty sure that would have bought her a tube.
Yeah.
Almost 100%.
Right.
So what you did was, I think that family not knowing what could have happened, it's a blessing what you did, because she would have had to have had a tube and potentially even still be on drops, and she's on nothing, and that retina looked pristine. So that was more than a win.
Yes, sir.
When I understand that there are no guidelines for the use of steroid preserving or steroid medications, but when do you use them? Because, for instance, in Wegen's granulomatosis, in Fanconi, Harad, etc., we tend to put the patients on methotrexate or other medications
Right.
sooner than
Actually,
before.
I had a slide on that, and then when the computer crashed, I skipped it accidentally. But my suggestion is if the patient cannot be on a safe dose of corticosteroid, either oral and or topical, then that buys them systemic therapy. If they have a diagnosis systemic diagnosis that requires therapy, so the ones you mentioned, right? Because in addition to ocular complications, they can have systemic complications of the disease. That also buys them systemic therapy. But that patient should already be seeing rheumatology anyway. So I think if the patient has already lost one eye from complications of inflammation and the other eye is at risk, I think that's also a situation that buys that. So the case I presented where the patient is at risk for complications even if they haven't had it yet, but you can kind of see that that's coming, that's also an indication. So these are not written in stone anywhere, but those are my general guidelines. I think we don't have
I
time,
think we're going to save
but I
questions
will
for
stay
later.
around if you want to ask me
Thank
any
you for
questions.
your